On behalf of the Faculty of Medicine at Al-Azhar University, I would like to welcome everyone cheering in this prestigious webinar, Al-Azhar International Pediatric Surgery Meeting in collaboration with EPSA and WOFAPS. I take this opportunity to thank our Pediatric Surgery Department and of course his chairman, Professor Sulaiman Muhammad, the director of this webinar. Also, special thanks for Professor, my colleagues and my dear friends, Muhammad Abdulaziz, the moderator of this webinar, and the Vice Dean for our faculty. Really, I am very proud of Pediatric Surgery Department at Al-Azhar University, not only for organization of such meeting, but also for great scientific contribution. Special thanks should delivered for all speakers and panelists, Professor Juan Carlos, Professor Fabio Chiarenza, Professor Samih Shahata, Sharif Shahata, Professor Magid Ismail, Professor Ahmed Durgham, and Professor Abdelmanem Shams. Lastly, I wish fruitful, successful meeting for all of you, and thank you.
Thank you, Dr. Hussein.
Thank you very much. Thank you, Dr. Hussein.
Thanks, Professor Hussein Abulghait, for your kindness and your warm speech. It seems that whatever comes from the heart goes to the heart. In fact, Dr. Hussein is always all sweetness and light, and our faculty is obviously prospering under his wise administration. And please let me to exploit this chance to congratulate our lovely colleague, Professor Muhammad Abdulaziz, the Professor of Pediatric Surgery at Al-Azhar University, who is moderating today's panel for picked up as the Vice Dean for Scientific Research and Postgraduate Studies. In fact, we all proud of him, especially. He is known for his motivation, enthusiasm, and dedication. So please let me pass the mic now to Dr. Muhammad Abdulaziz to welcome and to introduce our distinguished speakers. Dr. Muhammad.
Thank you, Professor Sulaiman, for this nice word I don't reserve. I would also would like to thank Professor Hussein Abulghait, the Dean of the Faculty of Medicine. He is actually a great spinal surgeon, and he made a lot for this topic. So welcome you, and we appreciate your presence and join us. I would like to welcome you all in this meeting, and I will move through the program tonight, which will include 3 presentations and 1 panel. Let us start with the first speaker. He is my dear friend, Professor Fabio Chiarenza. Dr. Fabio is the chairman of Pediatric Surgery and Urology Department, Vicenza, Italy. He was president of the last ESPES Congress in Vicenza. He is well known and famous pediatric surgeon and also urologist. He has many friends in Egypt and recently gained a lot of fans. The mic is yours, Dr. Fabio, please.
Yes. Okay. Thank you again for the kind invitation. I'm very happy to see you healthy because I see you very well. We came from a bad period, as I told you before, because it was a period very sad for us, for all the Italian people. We were struck from this terrible epidemic. The pandemic was terrible here. And now this is very good opportunity to meet again my dear friends, Egyptian friends. We are Mediterranean people. There is also Juan Carlos, that is the one that is connected with us. And this is a special evening to me, because I found in your friend a lot of similitudes from Italian people. And this evening I will speak about my lecture. Will speak about the hyperhidrosis. I know that in Egypt we had a lot of experience because I saw in the previous meeting that we treat in a lot. I don't know how many centers, but I saw some lecture on this this argument, and now I will try to make a resume. I apologize to you if some information are already well known, but this meeting is addressed to all the people, also to, I think, to new pediatric surgeon. So if you want to, I can start now, and I hope that during the presentation you can obviously stop me and ask if you have any question.
Okay.
Okay.
Please share your screen.
Okay, I try. Works?
Yes, great.
Okay. Okay. So, hyperhidrosis, primary hyperhidrosis is a debatable topic because we know that is already knows pathology, very hidden pathology, because not a lot of people can manifest, can show this problem that is sometimes hidden, but the incidence of this pathology is quite high, because 1 or 3% of the population. So it means that 3 people on 100 people are symptomatic patients, and sometimes live all his life in a bad condition, because can have any kind of communication, above all with the hands. So can be a very bad problem, above all in the adolescence, when the guys have to start his social life. We know that this kind of pathology is, as I told you, probably underestimated, because the incidence declared is 1-3%, but probably is a little bit higher, and is more common, we know, in hot, humid climates. Probably in Egypt we have a lot in incidence a little bit higher, and there is also prevalence with the racial groups, Middle Eastern, Jaws, Japanese people, and Taiwanese people. We have to underline that there is also a genetic link till 65%, with a high penetrance, 25%. And when you go through the anamnesis to the history, to the clinics, you see that sometimes you can saw that sometimes there is a familiar member that is affected for this problem. And we have, we can distinguish hyperhidrosis in 2 main groups. There is primary hyperhidrosis that can be focal, usually, with the onset during the childhood, as I told you before, or prevalence in the adolescence. And in 68% we have the prevalence for the axillary hyperhidrosis, but a similar incidence is for the palmar hyperhidrosis, that is for sure the worst clinic signs, because compromise the social life of the adolescents, and we go directly to hyperhidrosis of the foot, that is hidden, obviously, but is about 64%. And finally, in 30%, we can have also craniofacial, groin, and also submammillary place. Usually is not localized to the hands, to the axilla, etc., but is multifocal problem. The worst is on the hand, but the patient suffer from also other districts of the body. Then we have the secondary hyperhidrosis that is caused by other underlying condition, and sometimes could be the effect of medical or procedure or medication procedure. We have here a lot of causes. and that must be searched during the anamnesis of the patient. We have a look to the physiology of normal sweating. We know that there is usually the sweating is produced by two kinds of glands. The eccrine sweat glands that are all over the body, in prevalence in the axilla, palms, soles, and forehead, are mediated from postganglionic sympathetic fibers, and are for sure secretion clear, odorless, and the aim of this kind of secretion is to refresh the skin when there is a high temperature of the skin, is directly mediated by hypothalamus stimulus. Then we have the apocrine sweat glands that also are in the axilla, nipples, periumbilical region, anogenital region. And the characteristic of this kind of glands is that they start to work at the puberty, and above all, the characteristic is that they give an odorous fatty acid, and so the smell of the axilla and etc. As I told before, the main regulator of the producing of sweat is the hypothalamus. Hypothalamus, when the body temperature became higher, start with the stimulus to produce the sweating, above all eccrine sweating, to refresh the body. And go directly to our argument, our topics. We know that the sweat glands are innervated by the somatic branch of sympathetic nervous system. That its outflow is from the T1 to T12 vertebral bodies, and any district is a tributary of a kind of the body. For example, we have T1, T2, the head and the neck, T2, T7, upper limb, T4, T12, the trunk, T10, T12, the lower, the feet, the leg, etc. The neurotransmitter, terminal neurotransmitter for the sweating are mediated from acetylcholine that has some receptor, muscarinics, to locally. How can we do the primary diagnosis of hyperhidrosis? Is mainly a clinical diagnosis. We don't need any particular examination because the clinical signs more evident is, for example, the wet hands, but also other districts, and the clinical approach is very important. We have a lot of classification. We can classify focal, generalized, with a lot of characteristics, but finally, we know that we have specific and characteristic findings that we will find in the patient that is suffering from hyperhidrosis. Usually our patient young, healthy, with probably a family history of hyperhidrosis, more or less than the son. The onset is typical in childhood or adolescence, but obviously we can have also sometime before. Is usually bilateral, not monolateral, symmetric, palms, soles, axilla, and other specific body areas or combination of body areas. And the sweating, regardless of external temperature or external stress, is linked also to the stress and the temperature or external temperature, obviously, like in normal people. Another characteristic is that sweat is not during the sleep, when the patient sleeps. Usually there is a little production of sweat during the nighttime. Which patient we have to treat? We have to treat the patient that suffer psychologically this problem, because we know that the adolescents suffer so much this problem, very much, when they have to live socially, because they can shake the hand, they have to continue to clean the hands on the pants or something else. They hide the hands, and so this is the main problem. We can treat, usually there is a scale of classification of this kind of pathology, and we treat usually the scale 3 and 4. That means that the sweating is barely tolerably and frequently interfere with daily activities, or is sometimes intolerable and always interfere with daily activities. Sometimes we can treat also patient with kind 2, but we suggest to type 2 hyperhidrosis to use other medication or general medication, medicine, etc. So the scale is very important. Why? Because it is quick, as you see, easily understood by the patient, and can give a quantitative measure of the severity of this problem. Further, in the post-treatment, can give the success or less of the therapy, and we can also measure the success of the therapy when we, in fact, when we have, for example, the reduction of the improvement of 1 point, obviously in high, so we have 50% of sweating reduction. When we have 2 points of improvement, we have till 80% of improvement. It is very, very good for the patient also to compare the results. There are a lot of questionnaires for older children, for young children, that must be filled just before the operation and after.
So Fabio, 5 minutes left.
Oh, sorry. Okay, I go fast. Okay, if I go fast, sorry, because I forget the time. And so we know that we have typical signs of the action. The therapy can go directly with the topical agents or anticholinergic botulinum toxin that we will see after, or what we will do, the sympathectomy. We know that for the topical antiperspirants are containing, above all, aluminium chloride, are effective but not so effective. They have to continue to put it, and with fair results. If you speak about the systemic medication, we can speak about, above all, the anticholinergic drugs that can block the synapses of acetylcholine, peripheric acetylcholine. There is typical of oxybutylin, or that has mild good effect, or glycopyrrolate that give mild poor results with less side effect and with very high cost. Finally, for the therapy, there is botulinum toxin that is injected in the hands, above all on the axilla. It is painful, and it must be repeated, usually every 4 months. So it's not so effective, above all, for the compliance of the patient. I go faster for iontophoresis. There is another therapy that can be made also at home, but also this kind of therapy is temporary, and it needs continuous repetition every week, about every week. Go fast to the thoracic sympathectomy. we know that the focus for the sympathectomy is the thorax. The T2 and T4 ganglia. The thoracoscopic approach was described in 1951, first time, with open surgery, obviously. And this kind of technique was spreading with minimal invasive surgery. About 15 years ago, we start with this technique. This works very well for to stop the sweating. The problem is that sometimes we can have the compensatory sweating that can be a great problem. For the, we can debate about the size, the level of the interruption of the ganglia. At the beginning, the surgeon started with G2 ganglia, then G3 and G4. But now there is a consensus that says that for the pulmonary hyperhidrosis, it's better to go directly to G4 because it guarantees a very good result with low compensatory hyperhidrosis. This is internal view of the vertebral bodies. This is on the right side. You see, this is the first rib, the second rib. That is the first one that you see in the thorax, the third rib, the fourth rib. This is the point where we have to go for the axillary hyperhidrosis. On the right side, sorry, for the pulmonary hyperhidrosis. On the right side is the same. On the left side is the same. And for the axillary hyperhidrosis, we have to go with the G3 and G4. There's a nice result, above all for the hands, not so effective for the axilla. And it gives also a bad compensatory hyperhidrosis. We can decide to excise completely the ganglion. This is effective, it is very good because the result is very good. But we can also do a partial, a simple resection of the connection or the positioning of the clips. Which are the advantage of the clips? The advantage of the clips could be, but are not so, in literature, are not so, push here is that if you have a compensatory hyperhidrosis too high, you can remove the clip. But this is very debatable because if you remove the clip, sometimes you can go back. And so you must remove the clip in at least in 14 days, not after, because otherwise you have no results. So fastly, you have also to remove not only the ganglia, but also the communicating rami or branch of the ganglia, because sometimes you can have some collateral communication that can give bad results. The treatment is with, I suggest you, with selective intubation. The position can be usually on the supine position that can leave you the access in the bilateral side. You spare time, but the problem is that the scars are not so nice. It's better to go directly to the lateral decubitus because you can use 3 trocar, 1 or 5 millimeter, and another 2 or 3 millimeters. You go directly to the ganglia without with a good control, surgical control, or also of eventual bleeding, and the success is guaranteed. But we can do also a 2 trocar access with an optical device of 5M with operative channel and another forceps of 3M without trocar. This is very nice for the aesthetic, but it's not so good to control eventually the bleeding and for the vision. And finally, we can have 1 trocar access with 5M camera with operative channel. that give a bad vision and not so good. And then there are some other approach proposed in literature, for example, single incision of sternal incision of my colleague give me an submammilar incision directly without anesthesia. General anesthesia is very strange, but I have to I would like to show a video, but probably I have no time. If it's for 1 minute, I ask the permission to do it or not for me. Okay.
Okay.
Okay. This is a fast video. This you can see here the sympathetic chain just below the pleura. You have to open the pleura. In this case, we used was one of the first cases. We used monopolar hook. I suggest you to use bipolar hook because the spreading of the energy is very low. You see here the ganglia. Okay. Here you see the ganglion stellatus. It is very dangerous for the Claude Bernard Horner syndrome, so you must pay attention here. This is the second rib, okay? This is the ganglion that it was interrupted. This patient had a general hyperhidrosis, and so we decided to cut G2 to G4, yes. But was extremely rare. I don't suggest you to do this kind of procedure because the compensatory sweating is very high. So you see that we are moving now down. It's very fast operation, probably 10 minutes. And finally, you see we remove completely. Is about 4 centimeters of incision. Okay, I show you. The postoperative period is very short, 24 hours, usually 48 hours. The scars are very, very limited. This is a patient operated 2 years ago. It's difficult to find the scars for 3 millimeters. Pay attention, as I told you, compensatory hyperhidrosis that can be treated with eventually treated with restriction of the weight, no thermogenic diet, avoiding excessive people, and I finish now. And other side effects, the worst is Claude Bernard Horner syndrome when you go directly to G2. Pay attention because with monopolar hook, you can damage the gangliostellatum. Thank you for your attention and sorry for the late. It's not usual.
Okay, thank you, Dr. Fabio, for a nice and inclusive presentation. The next speaker is my friend also, Dr. Juan de Agustin. Dr. Juan is the president of the Spanish Society of Pediatric Surgery. He is the chief of Pediatric Surgery Department, Children's Hospital, Madrid, Spain. He is a well-known pediatric surgeon, not only in Egypt, but all over the world. He also have a big fans. And now the mic is you. Please share your screen, Dr. Juan.
I hope you can see now the slide.
Yes.
It's okay? Okay.
Yes.
So thank you. First of all, thank you for inviting me to this to talk about this topic. It's always a pleasure to be among friends and the opportunity to share. One of the things that I like the most is thoracoscopy and thoracic conditions. So I want to talk about this special topic, how to choose the right level for sympathectomy. Because I think we are over-treating most of our patients, and we have to try to avoid compensatory hyperhidrosis. So I'm going to talk about some anatomic landmarks to identify the right level for sympathectomy. And I will talk about how to treat different focal hyperhidrosis. As Fabio said, this is a disease that is an excess of production of sweat, and it's very common among teenagers. So I'm not going to go through these figures, but this is affected women and men equally, and it's very common among the general population. And it negatively affects all areas of life, among friendship, work, partners, and family members. So we're going to talk about this and try to address the best place to perform sympathectomy. This is a very interesting work done in 1942 that was published by the American Medical Association. As you can see in the right figure, there is a woman with it was done a sympathectomy at the third level of the thoracic sympathetic chain in the left hand, and a fourth level in the right thorax. The patient was applied with iodine starch all along the anterior thoracic wall. As you can see, the sweating is worse, it's up in the left part. So this is a very interesting result, showing that a high level, like T3, is related with dry hand, and T4 is related with a more lower level, like axillary area. So we have to try to apply this lesson in our patients. We can see in the left figure the anatomy of the sympathetic chain. And as Fabio said before, the ganglia is right behind the rib. The G2 is, the ganglia of the second level is behind the second rib, and the ganglia of the third level is behind the third rib. But and there is an accessory rami that cross over the rib in a downward fashion. So, as Fabio said also, at the beginning, 25 years ago, we started to do sympathectomy, and we started to do a T2 and T3 levels, even T4, because we wanted to treat and not to fail sympathectomy in our patients. So we were very aggressive, and almost these cunts, rami, were also burned or removed. But then we realized that we had a lot of compensatory hyperhidrosis and started to reduce the levels. This is the same picture Fabio placed in his talk. And you can see here very well this accessory rami that you have to take in also when you are performing sympathectomy. And there are technically remove the ganglia or just cutting the chain at the level of the rib. So, but this can regenerate, and if you only cut by a single, in a very small place, you can have a recurrence because it can recanalize. So it's better to remove a small portion or to apply electrocoagulation to destroy at least 1 centimeter of the trunk. So thoracoscopic sympathectomy is very well known technique, and the objective is to reduce excessive perspiration and to cause minimal reflex sweating or compensatory sweating. 80% are satisfied, and improvement in general is almost 90%. But these are the level. We have a T3, T4, and T5. We have the ganglia, ganglia 4, ganglia 5, and sympathectomy above, over the rib, the fourth rib and the fifth rib. But to try to avoid compensatory or reflex sweating, we have to know that there is an afferent fibers that comes one level above the ganglia we are going to remove. And there are efferent fibers. So there are a signaling and a kind of balance in between afferent and efferent. So if we remove 2 levels, we are reducing the afferent signal above, and we are also reducing the efferent signals below. But if we reduce the afferent signal, what happened is that the sympathetic activity increase, because the body thinks that you are not sweating. So we are producing more sweat. So in order to avoid compensatory sweating, we have to try to do only one level of sympathectomy. So if we perform only one level, we only cut or remove the efferent signal. And if we do 2 levels, we are cutting afferent and efferent of this level. So we are producing compensatory sweating. So there are some works, they are not very recent, but they are very, very good works. In the recent years, there are series, but these are very interesting because this is an outcome after sympathectomy in 100 patients, and about palmar, axillary, and plantar hyperhidrosis. And they saw that when sympathectomy was done, they could control 77% of patients with palmar hyperhidrosis, 57% of axillary, and only 8% of plantar hyperhidrosis. And only improvement was 22% in palmar, 31% in axillary, and 33%. And there is compensatory sweating, or even in the axillary and plantar patients. In general, quality of life improved, except of compensatory sweating, with different scales in this. But they had that. The problem was that the compensatory sweating. What happened if ganglia is not removed and only sympathectomy is done? Well, in this work, they use this scale, and they observed that with this scale, if they perform surgery in between 20 and 40 points, they are good candidates because 100% of them had good results for palmar and axillary. So they advise to use their scale. What about ganglia ablation? The results are the same, applying the same scale. They are from Taiwan, people, very, very good people with a lot of experience. And then another interesting thing relating to compensatory hydrosis is the work done with unilateral versus bilateral sympathectomy. And they did bilateral 1 stage, or unilateral, and later on, after a median of 4 months later, they perform the contralateral side. And they observed, they were similar groups, but they really observed less compensatory hyperhidrosis when 2 stages were done. And I say that it is between at least 1 month later than the unilateral side. So in conclusion, it's very important to decide the level of sympathetic ablative surgery in order to have good result and no compensatory sweating. So it depends on the type of focal, if it's palmar or axillary or feet. T2 is not acceptable because it has a lot of compensatory hyperhidrosis. So, and also it correlates with the total number of ganglia excluded. So if we removed two ganglia, we are having more compensatory hydrosis than we remove only one, or we remove three. It's a lot of compensatory hyperhidrosis. For palmar hyperhidrosis, it seems to be very good result with quite a few compensatory hyperhidrosis if we only perform one level, either T3 or T4, better T3. And for axillary hyperhidrosis, it's better to do it only one level, T4 or T5. And also has been interestingly reported that feet hyperhidrosis improved if you perform a T5 sympathectomy. So I think we have to address the type of focal hyperhidrosis in order to choose the right level. And that's all, and thank you very much. And I recommend, if you have the opportunity, to review this consensus of the Society of Thoracic Surgeons. It was a paper published in Annals of Thoracic Surgery in 2011. It has a very, very good synthesis, summary of all the knowledge up to this time. Thank you very much. Thank you.
Thank you, Dr. Juan, for this nice and illustrative presentation. Actually, you and Fabio covered most of the topic and answered most of the questions of the panel already. Thank you. Now we'll move to the next speaker, Professor Maged Ismail. He is the past president of the Pediatric Surgery Unit in Al-Azhar University. He is a well-known pediatric surgeon and laparoscopist. Please, Dr. Maged, share your screen. Dr. Maged, yes.
Thank you very much for the welcome to this interview. Really, I thank Dr. Suleiman and Dr.
Full screen.
Moderator
Yes.
Actually,
الصوت يا دكتور ماجد مش واضح.
Just one moment. Yes. Now good?
تمام يا باشا.
Can you mute one device, Dr. Maged? Can you mute one device?
Yes. Thank you very much for this opportunity to be with all of you. And I welcome Professor Juan, my dear friend, and Professor Fabio, my dear friend also. Thanks to Dr. Suleiman, the moderator of this webinar. At the start, I will present the sympathectomy experience at Al-Azhar University. Actually, I have in my topic why we have selected this topic for this presentation with EPSA. And the incidents and the material, I think Dr. Fabio and Dr. Juan have been fulfilled almost all of the presentation. What I can said as the selection of this topic, that normal sweating is essential to control temperature. Hyperhidrosis in children is a problem. It forms 1 to 4% of the population. In our country, we have 100 million population, so that we have about 3 to 4 million of Egyptian people. 60% are children, so that we have a lot of cases. But in spite of that, we didn't see a lot of those children coming to us seeking for the surgical or medical treatments. It could affect hands or fingers or armpits, feet or groin or elsewhere. The problem of this disease, it is a non-killing disease, so that most of the children does not come asking for the surgical or medical treatment. But actually it affects the lifestyle to a great extent. It may gave social embarrassment or social reclusiveness. Sometimes it causes occupational problems with stressful occupations, or make the hands of a child during writing or during handshaking is wet, so that affect the psychology of the child. So that the lifestyle of those children is greatly affected by this disease. In spite of that, we didn't have a lot of cases. In spite also, our country is a hot country, so that actually we are in need to propagate the knowledge to the community, to let him seek medical or surgical treatment. We should put in mind the secondary causes of hyperhidrosis, including obesity, anxiety, hyperthyroidism, and children also. Unsatisfactory medical treatment is also an indication of surgical interference. Using the topical creams, the systemic anticholinergics, iontophoresis physiotherapy, or Botox, all these medical treatments actually not satisfactory for children. So that at the end, we are in need for the endoscopic thoracic sympathectomy, which is the ideal, which is the standard type of surgery that should be used for those children. Outpatient surgery, it is an outpatient surgery so that no hospital stay so much. It is give a very cosmetic results, so that no much scars following this type of surgery. The child go to work and to school again within 2 days. The surgeon dignity, immediate results could be gained, and at last near 100% patient satisfaction. So that the endoscopic thoracic sympathectomy is the standard, the ideal type of surgery that should be used. I remember from my history that I have started this type of surgery since 1992, also on my section. And we progressed along the technical selection and how we avoid complication, the number of cases, the recurrence, and the technical failure of this procedure. And I remember also that there is multiple indication, Raynaud's, causalgia, arterial insufficiency, even heart angina is also an indication. But the most common is palmar hyperhidrosis, axillary hyperhidrosis, scalp and facial hyperhidrosis, and plantar hyperhidrosis. This is the view showing the palmar, the plantar, and so on. The technique, which is interesting to us as a surgeons, I think I go to the history from what's called Gonzalez crushing clamp. He used a special clamp to go and just to crush the sympathetic chain, but actually there was a repeated recurrence. Sympathectomy is a very good indication recently, cutting the sympathetic chain between clips, or sympathectomy with excision of segment of the ganglia. And you have enjoyed to a great extent the comments of Professor Juan about this procedure. Yes, this is the same anatomy, second rib, third rib, fourth rib, and the fifth. The ganglia of the second, just below the lower border of the second rib, and third, and so on. This is a hint on the bottom of the right side and the left side. Now, I show the audience just a rapid video about sympathectomy. Yes, we start high up using the cautery. We open the dorsal and cerebellum, and then we go to the level of the fourth ganglia, and then we hook the sympathetic chain, and we cut it using the electrocutter. Now, in this case, we have seen this abnormal communicating nerve of Crotius, this nerve. If you didn't sacrifice, actually you will have recurrence. This is an example of the interesting cases that we have seen in our section. Now we go to the materials in our section. Actually, we have faced along the last 20 years about 1,200 cases. Age ranges from 4 to 16. Male to female ratio, 2 female to 1 male. Reversed despite the international is 1 to 1. Indication, we have operated on 2 cases of causalgia due to chest trauma and intercostal tube application, and 4 cases of renal disease. Recently, we have introduced only clipping of the sympathetic chain, and this is coincide what we have heard from Professor Agustin, that tackling of one level reduced to a great extent the compensatory hyperhidrosis, especially if you select the lower one. And this procedure actually proved to be very effective and give us the opportunity to re-extract the clip again if we have uncontrolled results, uncontrolled complication like the compensatory hyperhidrosis. This is how we do the clips. We do it nearly at the 4th or 3rd ganglia. Just clipping, very effective, and avoid the compensatory hyperhidrosis. We have run this MD study in our section. Yeah. Yes, this is the application of the clips. No need to cut in between, just clipping. Return us to the crushing of the sympathetic chain by Gonzalez from Greece. Yes, how to avoid recurrence. This is a big question given to us because we have 3 cases of recurrence along our career. Cutting only allow regeneration and may be the cause of recurrence. So that in order to avoid recurrence completely, you should excite the ganglia, including the white rami and the gray rami or any unexpected congenitally communicating rami. So that the excision of the ganglia is the surest way to avoid recurrence. But in the opposite way, it causes compensatory hyperhidrosis in 10 to 20% of cases. Also, removal of the ganglia will allow us to avoid the nerve of Contis and other communicating fibers like this case.
5 minutes to Magid?
Yes.
5 minutes, please.
Yes. So that the excision of ganglia, in one hand, avoid recurrence, but on the other hand, it gives the post-operative complication of hyperhidrosis, compensatory hyperhidrosis, a lot of cases of compensatory hyperhidrosis. Also, the duplicate nerve is one cause of recurrence that we should take care, and that it may be lateral or medial to the main sympathetic trunk. How to decrease compensatory hyperhidrosis? Actually, there is a big lesson we take today from Professor Tuan. 10 to 20% after excision of the segment, so that sympathotomy is good. 1% only following clipping. Clipping may be a good new technique for avoiding the compensatory hyperhidrosis. And allow us, if we have intolerable compensatory hyperhidrosis, that we can remove the clip again and correct the condition. Chronic back pain, in some cases, we may avoid this by avoiding touching the periosteum by the cautery, like in this case. Cauterizing the periosteum of the rib causes this chronic type of pain, so that we should avoid cauterizing the rib like that. Bradycardia may be a problem in some cases, in athletes and with problems of the heart. Clipping and the reversibility of the clip allow us to correct this bradycardia. In those cases, in athletes, we should take a consent about this problem for medical legal problem, so that clipping may be beneficial to correct compensatory hyperhidrosis, may be beneficial to avoid the occurrence of bradycardia that may occur. High frequency, how to avoid Horner syndrome. We should avoid the use of high frequency current. We should cauterize the sympathetic chain nearly in place. Avoid overstretch over the sympathetic chain. Avoid this dissection over the yellow bed of fat over the main ganglia. Ultrasonic injury recently used to avoid propagation of the electric current. In conclusion, this is the way. In this case, there is overstretch, so that we have a temporary Horner syndrome in this case. This is an example how we can avoid development of Horner. Clipping may be beneficial. So that in conclusion, endoscopic thoracic sympathectomy is the gold standard technique of hyperhidrosis in our section. Refinement of the technique is mandatory to improve the results according to the energy current to be used, or clipping. Clipping from the sympathetic chain could be reversible with advantage over the bradycardia and compensatory hyperhidrosis. Thank you very much.
Thank you, Professor Magid, for this fabulous presentation.